So, hello, good evening, everyone. Today we are here to discuss about our Osh Mahotsav scholarship test number 2, which was on 15th April. Okay, and the subjects were pathology plus pharma. Okay, so I hope everybody has given the test. Now we will just quickly recall our whole questions, like 60 questions, quickly, and we will finish it early. So I hope everyone can see my screen and hear me. Okay, so today, this time we had three variant. Okay, in the first variant, the question was little bit different from the second variant. So I will discuss all the questions from first and second variant. In the third variant, I think most of the questions are repeated and mostly are from the pathology. Okay, because we forget to put about the pharma. So I will discuss all three variants one by one. So the first question was in our first variant when we are giving omperazole, it blocks the activation of clopidogrel by the inhibiting which enzyme. So in pharma, if you remember that we have two types of enzyme, microsomal and non-microsomal. Only microsomal can be induced or can be inhibited. Okay, so we have particular inducer and inhibitor for our microsomal enzyme. So if you know that inducers are griseofulvin, main we have to remember. So griseofulvin, other one is phenytoin. We have phenobarbitons, smoking, rifampicin. All of these can induce these microsomal enzymes, means they will increase the metabolism of that drug. Okay, so whatever drug we are giving, okay, along with that, if we will use any of these, they will increase the metabolism of that drug. So these are the enzyme inducer. What about enzyme, microsomal enzyme inhibitor? These are valproate, ketoconazole, cimetidine, okay, ciprofloxacin, erythromycin. All of these can block these microsomal enzyme or inhibit them, so they can lead to that drug toxicity. Okay, so we have, suppose we have taken one drug that is metabolized by these microsomal cytochrome enzymes. Now if we have used those drug with these enzyme inducer, then they can lead to the more metabolism, means they will be cleared out from the body earlier. If we have taken those drug which are metabolized by the cytochrome and cytochrome enzyme, then along with those cytochrome inhibitor, then they will lead to the decreased metabolism, means they will lead to the toxicity of those drugs. Okay, so these are the microsomal enzymes. These are our main inducer and inhibitor. Here they are asking about the particular omperazole blocks the activation of clopidogrel. So if you know, we have to remember some like cytochrome P3A4, okay, cytochrome P2D6, cytochrome 2C19, and one more cytochrome 2C9. Okay, so if for this cytochrome 3A4, you have to remember what drugs are metabolized by these enzyme. So the first one is all those cat drugs which will lead to the QT prolongation. So cat is cisapride, A for estimazole, and T for terfenadine. Okay, then cyclosporins. Okay, cyclosporins, tacrolimus, statins, and amiodarone. All of these drugs are metabolized by cytochrome 3A4. Okay, cytochrome 2D6 metabolizes beta blockers and antidepressants and all the antiarrhythmic drugs except amiodarone. Okay, so all the antiarrhythmic drugs, they are metabolized by the cytochrome 2D6. Cytochrome 2C19 metabolize or activate the clopidogrel. Okay, and when this enzyme is inhibited by our omperazole or all PPI. So whenever we are using omperazole with clopidogrel, omperazole will go and inhibit this enzyme. Then there will be no activation of clopidogrel. So here answer will be cytochrome 2C, cytochrome 2C19. Okay. So cytochrome 3A4, cat drug, cyclosporins, phenytoin, all of these statins and amiodarons. For cytochrome 2D6 metabolizes beta blocker, antidepressant, antiarrhythmic except amiodaron. 2C19 metabolizes or converted clopidogrel into activated form. So this enzyme is mainly inhibited by the omeprazole or any PPI. So if we are using PPI plus clopidogrel, this PPI will block the cytochrome 2C19, so clopidogrel will not be activated. Okay, and cytochrome 2C19 metabolizes warfarin and phenytoin. Okay, so these are the main enzymes you have to remember, and because of these enzymes, some drug which will block them, they will lead to their toxicity, whatever drug they are metabolizing. Okay, so here answer will be cytochrome 2C19. Next question was, what is the antidote of dabigatran? So dabigatran, if you know, this is our what about dabigatran? What is dabigatran? The answer is two. Okay, what is why we are using dabigatran? This is a anticoagulant drug. Okay, so if we are using anticoagulant drug, toxicity for dabigatran will be treated by idarucizumab. Transgenic acid, direct thrombin inhibitor, right, Prachal? Okay, adenosine alpha. Why we are using adenosine alpha? 10A toxicity and protamine sulfate. Today you guys have to answer me because I think everyone has finished these preclinical subjects. So why we are using protamine sulfate? Heparin toxicity, yes. And what about the warfarin toxicity? What drug we are using for warfarin toxicity? Okay. So, so dabigatran is thrombin inhibitor. Okay, this is direct thrombin inhibitor. So for this toxicity, we will be using idarucizumab. Transgenic acid, we are using no transgenic acid. Okay, and then adenosine sulfate. Adenosine sulfate we are using for factor 10A inhibitors and protamine sulfate for the heparin. For warfarin toxicity, we will be using vitamin K products or those also concentrates also plasma concentrates. Okay, and next question is, which of the following tests is used for laboratory monitoring of enoxaparin? So which of the following tests is used for the monitoring of enoxaparin? Do you know what is enoxaparin? Why APTT we will use for enoxaparin? For this question, answer is none, because for enoxaparin, this is our low molecular weight heparin, so we are not monitoring. Okay, for bleed this PT or INR, this prothrombin time and INR. For this, we are using this for our So the APTT is used for unfractionated heparin. Okay, this PT or INR we are using for warfarin toxicity. Okay, so for this answer is none of the above because enoxaparin is low molecular weight heparin and don't have more side effects, so we are not monitoring routinely. Okay, then next question is streptokinase was infused in a patient with management of DCT. Patient developed hematemesis. Which of the following agents should be chosen for hematemesis treatment? Okay, so hematemesis means there is excessive bleeding. Okay, vomiting, blood in the vomiting. So answer is tranexamic acid or epsilon aminocapric acid. In the variant, I have removed this tranexamic acid. Otherwise, the answer will be easy. So I have just kept it epsilon aminocapric acid. So the answer is epsilon aminocapric acid or tranexamic acid. Okay. Next is a 4-year-old child was undergoing surgery. Initial heart rate was 140 beats per minute. After starting anesthesia and start of surgery, heart rate dropped to 45 beats per minute. What will be next step? Next step will be we have to use our drugs which will induce the sympathetic system. So the atropine we will give, and atropine will induce the atropine will lead to the increase in BP. Okay. Next is which of the following is given to treat thrombocytopenia secondary to anti-cancer therapy is known to stimulate progenitor megakaryocyte. So since it is megakaryocyte, we will be using oprilcavir. Okay. If it is granulocyte, then we are using filgrastim, erythropoietin for RBCs, and iron dextran for iron deficiency. We will be using. So answer is oprilcavir. Next is 50-year-old male with type 2 diabetes mellitus is found to have 24-hour urine albumin 250 mg. Which of the following drug may be used to retard the progression of renal disease? Okay. So whenever you have studied that somebody with diabetes mellitus plus proteinuria, we will be mostly using the ACE inhibitors. So answer is enalapril. So answer is enalapril. Next is which of the following is given to treat thrombocytopenia secondary to anti-cancer therapy? Okay, so here it is not thrombocytopenia, granulocytopenia, because in the last, okay, so granulocytopenia, the progenitor is granulocyte, so answer is filgrastim. Okay, so this question has some mistake in the exam, so simply I have changed this megakaryocyte to the granulocyte, so answer will become filgrastim. Okay. 30-year-old pregnant woman has history of rheumatoid arthritis, managed successfully with the NSAIDs. However, she has recently visited her general practitioner complaining warning epigastric pain worsened by the food intake. Which of the following medication most likely contraindicated? So if you know that these NSAIDs are our non-steroidal anti-inflammatory drugs. These are our prostaglandin inhibitor. If you know that prostaglandin is required to protect stomach, okay? So these directly will decrease the prostaglandin level, and misoprostol is also a prostaglandin analog. So we will not give misoprostol. Famotidine we can give, omeprazole we can give, ranitidine we are giving. Okay, so the answer is misoprostol because it is asking about the contraindication. A patient presented in emergency with tachycardia, hyperthermia, bronchodilation, constipation. Person is likely to suffer with the overdose of. So what is the diagnosis? So if you know those sludge symptom, I hope you know what are the sludge symptom I am talking about. So the sludge symptoms we are using for our or you can remember those dumbbells for our cholinergic toxicity. Okay, so cholinergic toxicity means all the secretion will be elevated. Okay, lacrimation will be more, urination will be more. Okay, and eye pinpoint pupil. Okay, pinpoint pupil, and from the patient will have diarrhea. And from in the bronchioles they will have bronchoconstriction, but here the opposite thing is written: tachycardia, hyperthermia, bronchodilation, constipation. Okay, the overdose is mainly of atropine. If they want to ask about organophosphate, they have given us these cholinergic symptoms. Mushroom poisoning, for mushroom poisoning you have to not remember much. But the paracetamol, like paracetamol poisoning, you need to remember those King's College criteria and of acute liver failure, because the toxicity of paracetamol can lead to the acute liver failure. Okay, so this will be the answer of our uh, this question. So answer is atropine, because the symptoms are opposite: bronchodilation, constipation, patient is having tachycardia and hyperthermia. Next is imipenem, is a newer drug, new antibiotic. Then we have added with the which is a broad spectrum antibiotic co-administered with cilastatin. Best reason for the same. So we have to answer why we are using imipenem with cilastatin. Cilastatin. Okay. Why? Because this imipenem will go and inhibit the enzyme in the kidney, that is the dehydropeptidase. This dehydropeptidase will not metabolize this imipenem. So then the duration of action will be more. So cilastatin inhibit the enzyme in the kidney, destroying imipenem. So answer will be the D option. 35-year-old woman working in library at a high school noticed eyelid drooping while she was taking off her makeup before bed. After 15 days, she began to notice double vision, weakness while reading, and becoming progressively worse. She was advised to undergo laboratory tests by neurologist, anti-acetylcholine receptor antibody. So here, in the starting, she have ptosis, then she have diplopia. Okay, after that, in the test, they have written as anti-acetylcholine receptor antibody positive. Means the diagnosis is myasthenia gravis. For myasthenia gravis, drug of choice is pyridostigmine. Next is a 60-year-old male complain of type 2 diabetes mellitus, hypertension, dyslipidemia with BPH. He taking metformin 500 mg twice daily, enalapril, and rosuvastatin, tamsulosin. He underwent cataract surgery. In cataract surgery, significant intraoperative events happen by loosely hanging and blowing of the iris, progressive intraoperative constriction of the iris despite mediatic drugs, means that pupil is continuously contracting, and maintaining the was being added to maintain dilatation. Ultimately, prolapse of eyelids occur in from the dead wound, surgical wound, and leads to endophthalmitis. He also gave history of recent glimepiride 2 mg to his ongoing medical treatment due to uncontrolled sugar level. What are the complication? Okay, so if you know that tamsulosin has a specific side effect, that is the side effect is floppy iris syndrome. Okay, so whenever we are patient is taking tamsulosin and went for any eye surgery, there will be prolapse of that iris. So this is tamsulosin side effect, that is floppy iris syndrome. So the specific side effect goes to tamsulosin. Rosuvastatin nothing to do with this, and enalapril don't have any eye side effect. Glimepirides also don't have any eye side effects. Then the asthmatic patient since many years was stable on formoterol and budesonide inhaler twice daily. Oral montelukast once a daily is in combination with cetirizine and theophylline once daily at night time as bronchodilator. He developed pneumonia 3 days back. For this, we have given him antibiotic. He in this question, the mistake is that it is not it is now. He is now presented with nausea, vomiting, tachycardia, restlessness, and excessive urination, means diuresis. Which of the following drug is responsible for this complication? Okay, so if you know this this theophylline, okay, theophylline has is metabolized by cytochrome P1A2. Okay, and this enzyme is inhibited by few drugs. Those drugs are our antibiotics, and from antibiotics, the main one is ciprofloxacin, erythromycin. Okay, and so the antibiotics which will inhibit this enzyme is erythromycin, ciprofloxacin, cimetidine, OCP, and allopurinol. All of these drugs can inhibit this enzyme, so they will lead to the toxicity of theophylline, and theophylline toxicity will lead to increase in heart rate, nausea, vomiting, diuresis, tremor, seizure, and in severe toxicity, it will lead to the death. So here the answer will be ciprofloxacin. Okay, they don't have any relation to theophylline interaction, or I can say they don't have any drug interaction with the theophylline. So here answer will be ciprofloxacin. Other than this enzyme also induced by few drugs like smoking, phenytoin, and rifampicin. Okay, so these drugs can induce this cytochrome 1A2, and they will lead to the more metabolism of theophylline. So we have to increase dose whenever patient are taking these drugs. Whenever patient are on these drugs, then we need to reduce the dose to two-thirds, so they cannot lead to the toxicity of theophylline. Okay. Other than this, you have to remember this theophylline is working on so many receptors. Okay, the first receptor, if you know, this is phosphodiesterase 3 and 4 inhibitor. Okay, this is a 3 and 4 inhibitor. Other than this, adenosine A1 receptor antagonism, and it also leads to activation of histone deacetylase. Okay, so these are all mechanism of action of theophylline. Okay, so they can ask you ki, which antagonism will lead to the diuresis. So diuresis is caused by adenosine A1 receptor antagonism. Okay, so you have to remember all of these things. Okay, next question is 50-year-old patient requires suppression of emesis caused by anti-cancer drug he is taking. He also has a known case of diabetes, suffering from severe diabetic gastroparesis and GE gastroesophageal reflux, requires relief. Suitable for both indication. Okay, so here answer is metoclopramide, because metoclopramide is a D2 blocker. So if it is a D2 blocker, it is antiemetic, plus it is a 5-HT4 agonist. Okay. So if it is a serotonin agonist, then it is a prokinetic drug. So it will help in GERD. Okay. So the answer is metoclopramide. Why answer is not ondansetron? Because it is 5-HT3 blocker. Okay. And it is only used in early chemotherapy induced nausea vomiting. Same for aprititant. Neuro this is neurokinin 1 receptor blocker, and it is used in late chemotherapy induced nausea vomiting. Okay, but here patient want to treat his gastroparesis and GERD both, so we are using metoclopramide because it is having antiemetic effect plus prokinetic effect, so it will also help in GERD. So this will be the answer. Next is all of the following are rare but life-threatening adverse effect of thiamide group of antithyroid drug except. So the exception is lung fibrosis. Okay, because these carbimazole and propylthiouracil, they can lead to agranulocytosis, aplastic anemia, and liver toxicity. That's why in first trimester we are mainly using propylthiouracil, but in the second trimester and third trimester we are switching to carbimazole. Okay, with why in first trimester we are not using carbimazole? Because carbimazole has a specific side effect, that is cutis aplasia. So in the first trimester, all the organs and everything is developing, so we are avoiding carbimazole. But propylthiouracil, it is more having more liver toxicity. So in the second trimester, we are switching back to the carbimazole. Okay, so the answer is lung fibrosis. If you know, lung fibrosis are mostly busulfan. Okay, then the busulfan, amiodarone, all of these can lead to the lung fibrosis. Next is thrombolytics can provide relative mortality reduction treatment in acute myocardial infarction within 12 hours. Okay, so if they will ask you about acute myocardial infarction, we can use these thrombolytics till 12 hours. If they will ask you about the stroke, then we can use them up till 6 hours. After 6 hours in the stroke, uh, they will not give us any, or they will not give us any benefit over mortality, so we are not using. Then we will go for CT angio and those invasive procedures. So in MI, it is we can use up till 12 hours. For a stroke, we can use up till 6 hours. Next is, which of the following drugs should not be used in the setting of severe hypertension in elderly? Empirical treatment. Okay, so the empirical treatment, we are not using prazosin. Okay, we can use enalapril, we can use amlodipine, we can use chlorothiazide. Next is, which of the following diuretic causes hypercalcemia and can be used in recurrent renal calculi. So we have to choose that diuretic which will not lead to the hypercalciuria. Okay, so means this is having less calcium or excreting less calcium into the urine. So that drug is chlorothyroid, which is we are using in recurrent calcium stones, and also which will lead to the hypercalcemia. Okay, furosemide can has more urinary calcium, so we are avoiding this because it can lead to the more stone formation. Okay, next is 64-year-old man presented to the hospital with complaints of difficulty in breathing with brisk walking. Cardiac evolution is normal. Exercise-induced asthma is suspected. During general checkup, the intraocular pressure seems to be elevated. What medication we will give? Since they have mentioned he is having asthma and we want to manage the intraocular pressure, so which drug we have to avoid? We will be avoiding our beta blocker because they will lead to the more bronchoconstriction, so the asthma symptoms will be aggravated. So we are avoiding timolol. Which what is the concentration of adrenaline in cardiac arrest? The answer is 1 into 10,000 IV drug. Okay. Next is most common side effect of inhalational beclomethasone. The answer is oropharyngeal candidiasis because it will go and sit and leads to the growth of more candida. So that's why for the patient who are taking inhalational beclomethasone, we are asking them to do warm water gargling after using these sprays. Okay. Next is anaerobic bacteria are intrinsically resistant to aminoglycoside. Okay, these aminoglycoside will not work on the anaerobes. Okay, so the answer is aminoglycoside. And then next is 31-year-old woman has dull, constant abdominal pain for 6 months. CT scan of the pelvis shows 7 centimeter mass involving right ovary and contain irregular calcification. Histopath examination has concentric whorley deposits or called as Samoma bodies. Okay, so these Samoma bodies, if you know these Samoma bodies, we can found in papillary carcinoma, thyroid, all the papillary carcinoma of all the body, serous cyst adenoma of ovary. We can also find them in mesothelioma and meningioma. All of these places we can meningioma. All of these places we can find these Samoma bodies. So we have to answer what is the true statement. So true statement here is none of the above. Why? Because these Krukenberg tumor are mostly diagnosed. No, Krukenberg tumors are having signet ring appearance. Okay, so signet ring appearance is particular for these Krukenberg tumors. They are associated with CA 15.3. No, these are mainly associated with the breast cancer. Okay, they don't have any role. They are associated with secondary hyperparathyroidism. No, these bodies are not associated with these. So answer is none of the above. 33-year-old man presents with 5 week history of calf pain, swelling, low grade fever, serum level of creatinine kinase is elevated, muscle biopsy reveals numerous eosinophils in the peripheral with peripheral eosinophilia. Which interleukin is responsible for the hyperthermia? So for hyperthermia means fever, interleukin 1 is responsible, TNF alpha can also be responsible. So answer is interleukin 1. If you know interleukin 2 will stimulate NK cells, interleukin 4 we required for isotype switching of antibodies, interleukin 6 will stimulate acute phase reactants. So this is our answer, interleukin 1. During acute inflammation, histamine induced intravascular permeability. Histamine induced intravascular permeability formation of exudates. Which one of the listed cell type will be source of histamine to cause increased vascular permeability? When I was teaching you that steps of inflammation, I have told you histamine richest source is mast cell. So mast cell will release histamine. From endothelial cell, we will have B will palate bodies which will have a von Willebrand factor plus P selectins. Okay, lymphocyte, they can be, if they are B cell, they can form antibodies. If they are T cell, then they will form granuloma. Neutrophils are having all of those lysosomal granules. 3-year-old patient come to the hospital with hemoglobinuria, raised LDH, elevated bilirubin level. They are having target cell. Which of the following will be the answer? So hemoglobinuria means patient is having extravascular hemolysis. Other than this, more LDH means breaking down of the RBCs. More bilirubin will also show us this the same, and target cell. These target cell are specific, or we can say we will find in the thalassemia. So in the thalassemia, if you know, they have more hemoglobin F. They don't have more promyelocyte, no relation with them, no relation to the heptoglobin, no relation with the MAHA. So the answer is increased hemoglobin F, fetal hemoglobin. Next is 28-year-old female present with pallor and fatigue. She is a non-case of menorrhagia. Hemoglobin is low. Peripheral smear shows which of the following findings. So if she is having more bleeding, means she will be having low hemoglobin. Low hemoglobin because of less iron availability. The answer will be microscopic hypochromic RBC. Dacrocyte we will be seeing in those myelofibrosis disorder. These macrocytic hypochromic is nothing. Macrocytic hyperchromic we can see in B12 anemia. The patient is having rheumatoid arthritis. Hemoglobin is 4.5. Platelet is 2 lakh. Total leukocyte count is 6,000. Serum ferritin is high. Serum iron is 30. TIBC is 280 nanogram low. Means serum ferritin is high, serum iron is normal, and TIBC is low. Means the patient is having anemia of chronic disease because it is having rheumatoid arthritis. So why he is having rheumatoid arthritis? Because of this hepcidin activation, because they will block ferroportin and decreases the absorption of iron. Okay, so this will be the answer. Okay, this iron is not normal, iron is low. Okay, so this will be the answer. And these ferroportin, so these ferroportin proteins in the intestine will not allow iron to absorb. Okay, so there will be less iron, and also from this storage they will not allow iron to come out, so that's why they are having more serum ferritin. Okay, so the answer is hepcidin overactivation. If you know HFE gene, we will be seeing in hemochromatosis. Dietary insufficiency of iron is iron deficiency anemia. Okay, there is nothing like transferring overproduction. Next is a patient is generalized fatigue, tiredness. Primary clinical examination is uneventful, normal TLC, DLC, no immature cells, superficial discrete lymph node. We are finding then architecture indented nucleus, prominent nucleolus containing cells, CD10 and BCL2 positive. That what will be the diagnosis? So for the diagnosis, you have to remember that some CD markers. So for CD3, if you know, this is the marker for T cell. For the B cell, we have pen B cell marker is CD19. So this is B cell marker. If cell is having CD10, this is our Kala antigen. Okay, this Kala antigen for T cell, and they are also having, if BCL6 positive, then we can have two diagnoses. If they will ask you excessive course and extranodal involvement, and if they will give you history of Epstein-Barr virus, then the diagnosis will be the diffuse large B cell lymphoma. And if they will give you the history of c-MYC mutation, then the diagnosis will be Burkitt lymphoma. Okay. Next, if CD10 positive plus BCL2 positivity, then the diagnosis will be follicular lymphoma. So here they have given CD10 and BCL2 positive, so diagnosis is follicular lymphoma. Okay, this CD10 is for this is common ALL antigen. Next is a child is presented with history of pallor, fatigue, petechial bleeding, and fever for 7 days. Examination is having enlarged liver and spleen and sternal tenderness. Which of the following translocation explain the child symptom? Okay, so this answer will be translocation 812 because the diagnosis is Burkitt lymphoma. Okay, because petechial rashes, fever, enlarged liver, and spleen plus tenderness. The translocation is more common is 8. 40. Okay. The translocation 922, if you know, this is Philadelphia chromosome. Translocation 14, 16, these are our teen groups. So this will be our translocation 14, 16. No, 40. This will 14 and 18 will be our follicular lymphoma. Okay, so this will be our follicular lymphoma. So if you know that we have chromosome 11, 14 and 18. So if we have both these 11 and 18 translocation, this will be marginal zone lymphoma. If we have translocation of 14 and 18, then this will be follicular lymphoma, and translocation of 11 and 14, this will be mantle cell lymphoma. Okay, so this is the diagnosis is Burkitt lymphoma. Okay, I don't know about this option, it is correct or not, because I have read Burkitt lymphoma is having all translocation 8 plus even number. So this is also even number, but I think this needs to be written like this, then this can also be the answer. Next is all are true about aplastic anemia, except the exception is we never find hepatosplenomegaly in aplastic anemia. Next is most common type of lung cancer. The most common type of lung cancer is always adenoCF. Next is 60-year-old man presents with sudden onset blindness, frequent headaches along with sides of scalp. Means blindness is also there, frequent headache along the sides of scalp. Okay, so the diagnosis will be giant cell arthritis. If you know giant cell arthritis, the age group more than 50 years or mostly, okay, old age group they will give you, and they will say that they have throbbing headache, and they will have jaw claudication and also blindness. If ophthalmic artery will involve, the diagnosis will be giant cell arthritis. And the biopsy you will take at least 1 centimeter, because they have skip lesion. In biopsy you will see some giant cells. So the diagnosis will be giant cell arthritis. Next question is the younger age group, 30-year-old lady, weakness of the left upper limb, blood pressure is recorded in left upper limb, found to be lower than the right upper limb. Her aortic arch angiogram showed narrowing of the arch of aorta and subclavian artery. The diagnosis will be Takayasu arthritis, because Takayasu arthritis is also known as aortic arch syndrome. Okay, the other name for this is pulseless disease. Okay, so in this condition, the most common artery involved is left subclavian artery. The clinically we will find the BP difference in upper limb. Okay, and in the MR angiography, we will be finding this narrowing. The answer will be Takayasu arthritis. Next is 25-year-old patient, emergency room, severe abdominal pain, stool demonstrate occult blood, small infarct area surgically removed, histopathologically resected valve reveals fibrinoid necrosis of an artery. So in the last, when we were discussing, whenever we have fibrinoid necrosis, okay, so fibrinoid necrosis we can see in rheumatoid heart disease and pan malignant hypertension, all of these conditions. Okay, so this answer will be our pan polyarthritis nodosa, because they have neutrophil, eosinophil and mononuclear cells. Okay, and abdominal pain. So the answer will be polyarthritis nodosa. And this pan also associated with hepatitis B virus in 30% cases. So HBS antigen we can find positive in these patients. Next is a 12-year-old boy presents with the hemarthrosis of the joint, prolonged bleeding time following tooth extraction. Platelet count, bleeding time is normal. PT is within normal limits. Only APTT is increased. Okay, so if you know this PT, prothrombin time, we are using for extrinsic pathway. What are the factor for extrinsic pathway? Factor number 7, factor number 3. Okay, this APTT is we are using to check our intrinsic pathway. Okay, so for this intrinsic pathway, what are the factors? So if you know 9, 10, 11 and 12. Okay, and also 8. So these are our intrinsic pathway. We can check it by them APTT. Okay, so mainly they are asking about APTT is problematic, means these factors are having some problem. Okay, bleeding time is normal, means platelets don't have any problem. Okay, little PT is normal means no problem with the this extrinsic pathway, only APTT is problem. So the diagnosis will be hemophilia, and also they have written as hemarthrosis. So if you know this hemarthrosis means there is more blood in the knee joint, they will lead to the square shaped joint of this baby, and this also they also gave us a boy history, so it can be hemophilia A or B, because hemophilia C is autosomal recessive. This hemophilia AB is X-linked recessive. Hemophilia A is the factor defect of 8. Okay, so this will the diagnosis will be hemophilia. Next is a newborn develops severe umbilical cord bleeding after birth. Laboratory indicates bleeding time, platelet, APTT, everything is normal. Urea lysis test is positive. So when everything is positive, means the clotting pathway is normal. Okay, clotting pathway is working properly. Only the clot which is formed, that is not getting stabilized. So whenever, so that's why they are having recurrent bleeding. So this clot stabilizing factor is factor number 13. So we are having factor 13 deficiency, and for that we have positive urea test. Okay, so for this you have to remember few things like suppose if they will ask you that patient is having purpura plus bleeding time more. Okay, suppose they will give you a history of petaki purpura, bleeding time is more, then we will check the platelet count. Okay, we will check platelet count. If platelet count is normal, then we will check this defect with aggregation and addition. So if there is any defect with addition, how we will check addition? By ristostatin aggregation test. If this is abnormal, then the diagnosis will be Barnold-Solier syndrome, the defect with glycoprotein 1b and 9. Okay, so the diagnosis will be Barnold-Solier disease. Next, if this defect is with aggregation, how we will check? We will check with ADP collagen aggregation defect, or they will write ADP collagen aggregation is abnormal. Then the defect will be Glanzmann thrombasthenia. Okay, and the defect with 2b 3a. Okay, so the here platelets are not getting aggregated, here platelets are not getting adhered. So if platelet count is normal, then we can have only two defects, either addition defect or aggregation. If platelet count is normal, then we can have aplastic anemia or any other disease like ITP. In ITP, there is antibody against GP2B and 3A. But suppose if they will write to patient is having ecchymosis, hemarthrosis, okay, and clotting time is increased, then we have to check what about PT and APTT. If platelet time is more, then the diagnosis will be mainly with the factor 7 defect. Okay, so factor 7 defect, it can be warfarin toxicity will also lead to these platelet defect, or early vitamin K deficiency will also. If only APTT is more, then we need to see whether it is a child or it is a adult. If it is a child, then the diagnosis can be hemophilia according to their clotting factor defect. If it is a adult, then the diagnosis can be Epla syndrome. Next, if both are normal, APTT and this PT is normal, then the diagnosis will be factor 13 deficiency. But if both are abnormal, then we have to check for other condition like in DIC. It can be seen in DIC factor 10 deficiency, and also a fibrogenemia. Okay, so this is the gross chart you have to remember. Whenever they will write you like petechiae purpura bleeding time, then the disorder mostly with the platelet. If they will write you the clotting time more, then the disorder mostly related to the clotting pathway, either the extrinsic, either intrinsic, either both normal or both abnormal. So here the diagnosis will be factor 13 defect. Next is a 33-year-old man receiving massive blood transfusion falling from height. Within 4 hours of the last transfusion, he became breathlessness, oxygen saturation is decreasing, diffuse bilateral lung infiltration. True regarding except, so if you know this, this is mentioning breathlessness, hypoxemia, and diffuse bilateral infiltrate. The diagnosis is trially transfusion associated or transfusion related lung injuries. If you know in transfusion related lung injuries, JBP will be normal. Okay, so transfusion related lung injuries are mainly associated with HLA antibodies. So this option is also correct. Then next, true mortality is 5% in uncomplicated cases. Yes, because the cause of this will be most common cause of death in blood transfusion will be TRALI. So if uncomplicated, death ratio will be less. It is mediated by macrophage. Yes, it is mediated by the macrophage. It is more common in multipara donors. No, they don't have any such association. So here answer will be C. It is more common with multipara association. Since it is asking except means we have to find the wrong answer. Next is a 50-year-old male presented to ER with presented to the ER with severe bleeding in a road traffic accident. He found to have a known cardiac disease, anticoagulation therapy, and as a intern you are asked to collect the blood for the coagulation studies. Which vacuum thinner you will use? So if you know we have multiple types, multiple colored vacuum cleaners. So for vacuum cleaners you have to remember their like color with their product, whatever additive they are having. So this simply we are using blue one. Here we have list like this. Blue is having citrate, 3.2% sodium citrate. Okay, and what we are using this? So we are using this for coagulations study like PT, APTT, and D dimers. This dark blue is having clot activator. This red one is also having clot activator. This red one is having SSG plus silica particles. Okay, so these are mainly just to activate the clots. They are not having any anticoagulant, and these are for our serum studies. Okay, next is our golden one is also same, but it is not having any silica particles. Next is green. So light green and dark green. Light green is having lithium. Okay, lithium heparin, and the dark green is having sodium heparin. Both of them are for the plasma assay. Okay, like our ABG, osmotic fragility test, all of these things we will be checking here. In the lavender, we are having K2 EDTA. This is for the hemogram and platelet studies. Same pink one is we are using for the blood bank in the cross matching. Blood bank in cross matching. This dark blue one we are also using same K2 EDTA it is having, and we are using for the rare elements like copper and all of such things. This white one is having EDTA gel, and the gray one is having sodium fluoride. So this is for the glucose estimation. Okay, so these are our all vacutainers. You just have to remember their additives and their use. So here answer will, since we have to go for coagulation study, so we are using this blue one. If they will ask you about the hemogram or platelet study, we will be using lavender. If they will ask you about our plasma assay, then we are using green. Glucose estimation, we will be using gray. Next is middle-aged men come to the OPD with gum bleeding. Further checkup, peripheral blood smear showing 70% blast, MPO positive, increased TLC. So I have told you this MPO is myeloid precursor marker. Okay, so this is for the myeloid cells. Okay, so patient is having AML. Okay, so because if you know this AML is also having gum bleeding. Okay, so this is answer will be AML because they are having more TLC also. 45-year-old diabetic male suffering from chronic kidney disease having is on hemodialysis. From the a biopsy from the renal tissue is performed, what will be the amyloid depositions? If you know, beta 2 microglobulin cannot be filtered from these microfilter present in these hemodialysis instrument. So the answer will be A beta 2. Amyloid associated, I have told you where we will find in familiar Mediterranean fever. if it is mutant, or if it is more than chronic inflammation. AL, myeloid light chain, we will be finding multiple myeloma. ATTR, same, wild type and mutant. Okay, so this wild type we will be finding wild type we will be finding in systemic amyloidosis, and this mutant type we will be finding in familial amyloidotic polyneuropathy. Next is on light microscopy. Tissue comprises fibroblasts, leukocytes, blood vessel, and loose connective tissue in the wound. What will be the healing? So I have told you in the day 5 granulation tissue will come. Granulation, not granulation tissue. Okay, so in the day 5 we are having more of granulation tissue, same. So they are having more, means it is having inflammation, plus it is having our blood vessels, okay, and more fibroblasts. So this is will be the answer in the first week, because in the day 5 we will have more granulation tissue. Next is a 3-year-old boy present with recurrent bacterial and fungal infection involving his skin and respiratory tract. Total neutrophil count found to be decreased. Ineffective bactericidal capacity of neutrophil. Defective fusion of phagosome with lysosome. Okay, so this is the defect in phagocytosis. In phagocytosis, we use one list gene. Okay, so if lift gene is defect, patient is having defective fusion of phagosome with the lysosome. So they will accumulate inside those our neutrophils, those large granules. Along with that, other bodies lysosomes are also defected, so patient can have albinism, all of those things. So this is the diagnosis will be Chediac Higashi, which is a autosomal recessive disorder. Why not ataxia telangiectasia? Because they didn't mention anything, and ataxia telangiectasia is having this defect with ATM gene. Chronic granulomatous disease, the defect will be NADPH oxidase, NADPH oxidase defect. In Ehlers-Danlos, this is a collagen defect. Okay, so here the answer will be Chediac-Higashi syndrome. 58-year-old diabetic patient came to the hospital with complaint of sudden decreased urine output and confusion. On further examination, KFT of the patient suggested glomerular function to be severely compromised with GFR to be less than 10. He underwent successful renal plant, and after a month, the flaccid kidney is fine. So, what is the type of rejection? So, answer will be preformed antibodies. Since they have more type 2 hypersensitivity reaction than the type 4, so the answer will be preformed antibodies. Next is patient came in complaining of pallor, fatigue, malaise. His lab findings are having decreased hemoglobin, decreased MCH, MCV. So we will be writing the patient is having decreased hemoglobin, decreased MCH, decreased MCV, and in peripheral findings they have pencil cells and microcytic hypochromic anemia. So pencil cells and microcytic hypochromic RBCs with severe anisopoikilocytosis. What will be the treatment for the condition? So since everything is decreased, then the answer is iron supplement. Okay, in all of these conditions, we are having megaloblastic anemia. Next is pallor, fatigue, weakness. CBC is showing hemoglobin is decreased, MCV is increased, MCH is increased. What is the deficiency? So MCV, MCH increase means hyperchromic macrocytic. Okay. So that the answer will be vitamin B12 deficiency. I know Sevasi, same I am thinking. In Robinson also they have mentioned that hyperacute is preformed and acute is mainly with the cellular cytotoxic T cell. But I cannot comment right now because they have given me that answer and I have confirmed with that sir also. He is also saying the same and he have given me the same explanation which I am telling you. Okay, so if you need, you can ask that that sir who is here. You can ask him. Okay, the 40-year age man presented to OPD, generalized weakness, lethargy, and shortness of breath. Investigation is revealing normal methylmalonyl CoA is normal, only homocysteine is more. So, if you know, we have one pathway. This methylmalonyl CoA is forming the cytosine. succinyl CoA. Okay, and this homocysteine is forming methionine. Both of these are, this one methylmalonyl K is mediated by vitamin B12. Homocysteine is mediated by vitamin B12 plus vitamin B9. Okay, so if there is deficiency of B9 only, then we have defect only with the homocysteine. If B12 defect, then we have defect with both. So here they have mentioned MMA is normal, only homocysteine is increased. Then the answer will be B9, folic acid deficiency or folate trap. Same. Then, female presents with excessive bleeding after labor. Laboratory studies demonstrate decreased platelet, prolonged prothrombin time, partial thromboplastin time. Okay, so decrease platelets and prolonged PT time, prolonged APTT time, and increase fibrin degradation products, increase FDP. Okay, so whenever you will find all of these, and if they will write to increase fibrin degradation, then the diagnosis will be diffuse intravascular coagulation, and the answer will be endothelial cell injury will be the most common cause for this. Factor 12 deficiency will not have any such defect. Decreased fibrinogen level will not confirm the diagnosis because we have to check the fibrin degradation product. Okay, and vitamin K will not have any role here. Okay, so these are our all question. I think one question of pharma is missed in from the first variant, I think. In the first variant or which variant? So the third question of this variant 2 has missed. It is saying 6 members of a family were admitted to the hospital emergency with flushing of skin, tachycardia. So they have mentioned that patient is having flushing of skin. Okay, they are having tachycardia, means increased heart rate. They are having hypothermia, increased temperature, and constipation. Okay, and further they have mentioned about an hour before admission to the hospital, they develop symptoms of hallucination, agitation, and disinhibited behavior, playing with the imaginary objects, trying to pick imaginary things off the carpet, trying to throw things out of the closed window. They denied to use any hallucinogenic substance or recreational drug, and they stated consumption of a decoction that was prepared at home after buying a herbal product from an apothecary. Okay, apothecary means are the shop which are selling these substances, medicinal plants. The person is likely to suffer. So we have our diagnosis. So they have increased heart rate, increased temperature, and constipation. The diagnosis is atropine poisoning. Okay, so the atropine poisoning is the diagnosis since they have taken it from those areas. So this medicinal plant, so it can be because of dhatura, because they are sending some medicinal plants, so it can be because of dhatura. So the diagnosis will be atropine poisoning, because in dhatura or even belladonna, same na? Belladonna or this datura are having active principle of hyoscine or atropine. So the diagnosis will be atropine poisoning. If organophosphate, then they have to write pesticide. They have taken something, and mushrooms, then they have written mushroom. So they just simply said that they have taken some medicinal plant from this shop and they have consumed, and after that these family members are having flushing of skin, increased heart rate, increased temperature, and constipation. So the diagnosis will be atropine poisoning. For this treatment we will be giving them physostigmine. Okay, so here we have finished all our question. So for this atropine poisoning, if you know, patient will have dry mouth, all these symptoms, dry mouth, delirium, they have hyperthermia, agitation, tachycardia, increased heart rate, urinary retention, and accommodation lost or blood vision or photophobia. So for third variant, did you hear? Yes, from third variant out of 27. So here almost all questions have finished. If any left, you can tell me. I can explain them now. According to me, almost all finished. This one all finished. Other variant, variant one. First is also full done. In the third variant, variant 2, question number 14. I have told you now these aminoglycosides are in the bacteria having intrinsically resistant. Anaerobes mainly are intrinsically resistant to aminoglycosides. So answer is aminoglycoside. We can use for anaerobe, we can use chloramphenicol and metronidazole, but we cannot use aminoglycoside. That is also this is third now. I think all done. Variant 1, 21. So prazosin we are not using as empirically. Variant 2, 12I. Answer will be 1 in, yes. Variant 2, 12. Yes, it is 1 in 10,000 IV. Question number 26. Where is one? Question number 26. It is first week only because we have granulation tissue on the day 4. So the most probable answer is first week. Variant 1, question number 20. You mentioned some institution, mentioned option 1. Yes, because I also don't know. According to me, it is that acute rejection, acute cellular rejection. So cytotoxic T cell needs to be. So we didn't consider this question for all variants. So that's why I also don't know why this means though some institute have mentioned preformed. According to me, it need to be cytotoxic T cell mediated injury because they are more responsible for acute injuries. Because if he is having hyperacute, if you know hyperacute is within hours, it is only in the operative operation only. During the operation also we can find these kidneys becoming blue or something. But they and also if he is having hyperacute rejection, patient can feel pain. So that hyperacute is mainly because of preformed antibodies. But here you didn't consider three options from variant 3. You didn't. What I will show you in I know I can show you in Robinson. They have mentioned yesterday also. I have asked the same to that who has sent this question. I asked them. They said it is having type 2 hypersensitivity more common. So the answer will be preform antibodies. According to me, the answer needs to be B option. Next time, yes, Prajwal. Next time I will be making only. This time we were not having time now, so that's why. In the hurry we just make it because we have some urgent work, so we are not in a so yes, it needs no it need if it, the in question number 18, if they have given option like 2 8, then we can mark 2 8, but they have given 8 and 2, then we cannot mark. The most probable answer then will be 8 to 14 translocation because that is more common for the Burkitt's lymphoma. Any other question? Do you have any other question left? Then you can ask me. Soon I will be like I am deciding to create like small revision classes for every subject. Like for patho, in 1 or 2 class we will finish full patho. So we come variant 1, 3, third question. Variant 1, third question. For variant one third question, the enoxaparin. For enoxaparin, we are not using any monitoring because it is not having such more vitamin. Like if they will ask you for unfractionated heparin, then we will be using, okay. And if they will write to heparin, then also we are using monitoring. But for enoxaparin, no monitoring is required. And variant 121. Prazosin only. Empirical treatment for severe hypertension. After medicine subject, which subject? No, in I think 22 we have exam of medicine plus FMT. Then after I think we will be having surgery, ortho and radio. I'm not sure which one, but as I know, maybe this these subjects we can. Variant two, third question. In variant two, third question, I told you na they have consumpted something and now they are having flushing of skin, tachycardia, hypothermia, and constipation. These all will like take us to the diagnosis of atropine because organophosphate they will be having diarrhea, they will be having low heart rate, and in a mushroom we will not having such symptom. In amphetamine we will be having excitation. How many more tests will be? Tests will be every year. Now, from now onwards, WCIC will take tests. Like we will be continuing this series. In September also, we will be starting with the year wise. Like for anatomy, physio again, then two subjects. But every 15 days or 20 days in your curriculum, we will be adding one test. So every 15 days, maybe two subjects. There will be one test for two subjects, and you will get some scholarship also. Mm, For this year, I think one more because after that you will be having your GOS exam, so you will be busy, and also for your graduation convocation also you will be busy. So maybe according to me, I till now I only know one because after medicine one more, so we can say two. Variant one, six, and eight. Variant one and six and eight now. So those are same, okay. But in that time, I have told you that in the eighth question you can write instead of megakaryocyte granulocyte. So if they will ask you progenitor megakaryocyte stimulator, we will be answering operel vaccine. And if they will ask you progenitor for granulocyte stimulator, then the answer will be filgrastim. Yes, Jennifer. Like we will be having for short subjects it can be three, but for the big subjects it can be only two. Because if you saw that last time we have taken it for four subjects and the result was not that good, na? So we decided that we will be taking only two subject tests. So we will be giving you 15 days time, and after 15 days you will be having tests for those two subjects. Any other question? Variant two, first question. Okay, so that is about imipenem. Na? So whenever we want to use imipenem, it is very short acting. So it can be easily destroyed by the enzymes present in kidney, that is dihydropeptidase. So whenever we want to give imipenem, we are using it with cilastatin because cilastatin will inhibit that peptidase enzyme and leads to the more duration. But if you know the cilastatin is contraindicated in epilepsy because the side effect is for cilastatin is seizure. So the answer is D. Cilastatin inhibits an enzyme in the kidney, destroying imipenem. Variant 2, fifth. Okay, variant 2 in fifth, they have mentioned in that na he is not. That is not now, so we didn't consider this question also. So he is not present. He is now presented with nausea, vomiting, tachycardia, restlessness, and excessive urination in UOPT, means diuresis. So what happened? The patient is taking theophylline, and he after that he is having pneumonia. For pneumonia, he has taken some antibiotic. Now after taking antibiotic, he is having nausea, vomiting, tachycardia, restlessness, and diuresis. So which antibiotic will interact with the theophylline? So the theophylline has interaction with the ciprofloxacin, erythromycin, cimetidine, because they will block the cytochrome 1A2, which will metabolizing theophylline. So if we will giving these in ciprofloxacin with theophylline, ciprofloxacin will block the cytochrome enzyme which is metabolizing theophylline, leads to the theophylline toxicity. Okay, so because of that toxicity, patient is having such symptoms. Sevas, you got 20. How? Okay, which variant you are having? Variant 1. I don't know. You can come, go to office and you can check your that OMRC. I also don't know. Tomorrow you will go to office and you can check. You can go to after 2, I think. Any other question left? Variant 2, second. Variant 2, they have told, said now that eyelid is drooping means ptosis. Then after some time, patient is also having diplopia and weakness while reading. Okay, and which is getting worse. Then they have mentioned that patient in the he went to laboratory tests and they found anti-acetylcholine receptor antibody. Anti-acetylcholine receptor antibody means patient is having myasthenia gravis. For myasthenia gravis, we are using pyridostigmine. In some places, they have mentioned physostigmine, but the more probable answer is pyridostigmine. Variant of fifth. I just have answered ciprofloxacin. Variant of fifth, na ciprofloxacin. Because it will inhibit the cytochrome 1A2, which is metabolizing theophylline. Sixth. Sixth answer is D, metoclopramide, because he has taken anti-cancer drug causing MSS, so he wanted that anti-emetic effect. Plus, he is having diabetes. Because of diabetes, he is having gastroparesis and GERD. So he want to relieve from that also. So the if we want to relieve we want anti-emetic effect plus want to relieve from GERD, then we are using metoclopramide because it is having D2 blocker effect. Because of duty blocker, they are having antiemetic effect, means this vomiting will be subside. And it is also having 5-HT4 agonist, that serotonin receptor agonist. So because of that, it is a prokinetic and also it will help in GERD. Why GERD? Because it will increase the esophageal sphincter tone, it will increase the gastric emptying, so helps in gastroparesis and also increases small intestinal motility. Okay, if they will just ask you about the antiemetic effect, so then if they will mention that early cases, then we can use ondansetron. If late cases, then we can use aprepitant. Okay, so thank you so much for joining. If you have any question left, then you can text me